It is my sincere honor and pleasure to be on this panel where we are actually going to dig into kind of organizations and communities that are working on outcomes related work and how they do that. And so hopefully we'll continue to build on the incredible panels before, incredible conversations before. It's been highly inspiring, so this will continue to be inspiring. But I am going to note one thing. So those of you that want to ask questions, you're going to come take my seat and sit here and ask the question of the panelists. I am going to go sit right there, and y'all are going to come up here and ask the question. So you will have a direct conversation with the panelists about your questions, and not through me. So we're not going to talk after you. You're going to have to come here and have a question and talk about it. So I think it'll be a way to lighten this up a little bit, but just for fun, we'll try a new methodology. So I'm going to introduce our panelists. I'm going to start to my far right, John Siburt. He is at CitySquare Foundation. He's Assistant Vice President for Programs and President and COO of ACU at CitySquare, which is a partnership with CitySquare and Abilene Christian University. Sounds amazing.
Just President and COO of CitySquare.
Okay, awesome. What's so interesting about John is he was a minister. He might still be a minister, are you? Or no, you were?
Some have called me that. Some call me other
things. We will find out from this. At Richardson East Church of Christ. And he's been at CitySquare. How long have you been at CitySquare now?
It'll be 6 years in August.
Wow. And so look forward to hearing about it. I was telling him I was going through his website, and there's so much happening, and it's so exciting. So I look forward to hearing about that. Next to him is Vidya Ayyr. Vidya is the Director of Community and Social Impact at the Parkland, I'm going to get this right, Health and Hospital System. Are you at the system or is it the institute?
It's Parkland Health and Hospital System.
Okay. And she has her bachelor's from the University of Texas at Dallas and a master's in public administration from the University of Texas Health Science Center of Public Health. And she is doing some incredible work and interesting work, at least everything that I've had a chance to read on how Parkland is working with the community and social impact. So I'm really looking forward to hearing from you. And Dr. Kumar, who's to my right. And he got a very interesting background. He's both a doctor of medicine, he received his degree in India, but then came here and got his MBA at the University of Tennessee in Knoxville, and has learned the Six Sigma strategy and has been applying it in the work that he's doing in healthcare. So it'll be very interesting to hear about how you're looking at Parkland Institute and what happens in methodology, but also how do you think about outcomes and hospital delivery. So with that, I'm going to start with you, John. If you could just give us a little bit of background of what CitySquare is doing and how you operate, and then we'll move to Vidya and then back to Mark.
Sure. CitySquare fights the causes and effects of poverty through service, advocacy, and friendship. And we have about 17 different programs, so we often talk about them in terms of the 4 H's: health, hunger, housing, and hope. Our experience is that poverty hits people on all fronts, and so we try to hit back on all fronts. So that's why our work is so broad and so diverse. Is because poverty is very complex. And so we have a law firm, we have a clinic, we do housing, we do workforce training, we have a food pantry, summer and after school meal programs for kids, a big AmeriCorps program, we have a thrift store, opening a cafe, we've bought a historic theater that we're renovating, we've developed affordable housing. So the reason we're in all of these different sectors and areas is because poverty is in all those sectors and areas. And so we're trying to create a comprehensive approach to fighting back. So we do a little bit of everything. The key to our work is collaboration and partnership. So we think you save a lot more of the world if you don't try to save it all by yourself. And we believe in the wealth of the poor. So one of our sayings is everybody's rich and everybody's poor, just in different ways. And so what's really launched our work, we started 30 years ago as a food pantry. And what's led us into all these other aspects of the work is the wisdom and insight of our neighbors. And so we tell a story called the Josefina Ortiz story. She came into our food pantry needing help one day, got her assistance. The 2 women behind her were young Latina moms that didn't speak English, and Larry James, our CEO, was trying to help them, and he didn't speak any Spanish. And they were at an impasse, Josefina was coming back through with her groceries, and Larry said, man, if you don't mind, could you translate for me? Josefina sat down and conducted the entire interview and got both women behind her what they needed. And then had the good sense to say, you know, sir, I could come back tomorrow if you need me to. And Josefina came back tomorrow for the next 9 years. And we went from a food pantry being run by half a dozen burned out rich people from Highland Park that were doing their Christian duty, damn it, to 300 volunteers from the community, where we told people, hey, would you help us? And once we turned it over to the community, that's when we got a clue about outside product.
So you've kind of taken a outcome-based approach from the beginning in terms of how you need to involve. So look forward to digging into that.
You bet.
Vidya.
Well, so I've been with Parkland. Can you hear me? It's on?
That's great.
So I have been with Parkland Health and Hospital System for about 6 years too, and see, I just need the double mic. I'm always. And it's been wonderful because I was in a legislative affairs role before, and now I'm part of the Community Health Institute, and hearing John talk about CitySquare and other partners. Chad Hauser mentioned our relationship with them as well. So Parkland Health and Hospital System, with the idea of it being the safety net provider for Dallas County, has this huge presence in the community, and is the backbone of a lot of health-related things. And now under this new kind of wave of patient-centered care, we're able to kind of approach things from an outcome-measured standpoint. And so when we talk about human-centered design thinking, and social innovation, and then we apply it in the world of healthcare, that becomes patient-centered care. So that approach for patient-centered care is all driven by the patient's needs and the outcomes of health. And so you may have heard the term social determinants of health, and I think a lot more conversation is around that social determinants. And so what does that mean when it comes to the actual individual patient that comes to one of our clinics? And so let's talk this through, just like the story. The impact is in traditional medicine. We may have had a patient come in and receive treatment and care for a diabetes, a chronic condition, and that's the end of the story. But we know from working in the space that we're all in the social impact space, it's more than that. That woman, that patient may be a single mom. She may not be what we would have called non-compliant, but she actually may not be coming into her clinic appointments because she doesn't have childcare. She may be a minority female and also have other health constraints, and that's that intersectionality of healthcare that we're also trying to address with that piece of how do we become inclusive in our policies so we're seeing the patient from a very holistic standpoint. And so that's really some of the work that we're doing through that, and we can't do that without our community partners.
Yeah, I look forward to digging in as to how you play that role within the couple system and city partnerships. Dr. Kumar, you're the Vice President at Parkland Community Health, and I'd love to understand, how do you see the overall system, and how do you think about that?
So, I worked at Parkland about 11 years now. I started off in correctional health, spent about 8-9 years in student welfare, and also all the community clinics. And I also have my passion is about having a good design, so whatever we do, it is replicable and sustainable. And being a county hospital, I try to, I guess I need 2 mics too. My passion is to try to remove unnecessary work because I'm trying to stretch that out. There is so much patients who need our care, and we need to provide for all of them with the resources we have today. So, the Community Health Institute at Parkland has been in the making for the last 10 years. But we had other things we were working on moving to the new hospital. And now with the new leadership, we are able to go ahead and get started. We've been up and running for the last 6 months now. We're still learning. There's a lot of expectations, but one step at a time. A lot of passion, a lot of commitment, needs. Before we say this is what we want to do, we want to understand what exists today so that we don't duplicate efforts. Try to understand, respect, collaborate, and connect people as we build new programs. Just want to share a small story. I mean, healthcare has been driven by physicians all along. That is the old culture, writing prescriptions and everybody else executes. But the new model is the physician being part of the care team, right? And also the care team extends to the work everybody here does, because it's not about taking care of the headache, it is about treating the diabetes, and it's going beyond the diabetes, treating the patient. But then now we are all talking about helping a person, both not only addressing their immediate need, but also trying to prevent it from happening. So both primary, secondary, tertiary, and quaternary prevention. The last part is unnecessary work that is being done in healthcare that can be avoided. So we are focusing on all the different aspects, and we can do it all. We're not trying to try to do everything. So we're looking for community partners. A lot of good work. Everybody sitting here is adding value to what we do, and we want to be part of this group. So that what can we do as a healthcare provider?
So 2 questions. I'm going to start with Dr. Kumar and Vidya, and then John, I'll come to you in a minute. So let me just, it's easy to say that doctors are now part of a team. It's not easy to say, and it's not easy to do either. But what does that mean at the end of the day in terms of how do you get paid if you're not getting paid for number of people you've touched or you've seen or that come through your door? How do you get paid for people not coming back?
That's good. Excellent question. That is actually the problem with healthcare. Like somebody else said, the more sicker the person is, the more tests you do, the more visits you have. That's how we make it in healthcare. Right? But the beauty of our hospital is we are not for profit, and we are funded through the county. So everybody is salaried. So that is, you don't get paid more for doing more. It is. So the goal is how to maximize the people we have today. I don't believe that building more hospitals and hiring more physicians is the solution for access to care. It is about maximizing each and every staff member we have. So not every single issue needs to be dealt or goes to the physician's table for resolution. There is so much that can be delegated. And if 80% of the work can be done by others, then the others through consultation or through referral can be escalated to the physician. And that is a transformation we're doing.
I'm going to come back to that, how you're doing it. Vidya, in order for what I hear Dr. Kumar saying, it means that the work you're doing, that you're looking at the patients and thinking about the social determinants here. In order for the patients to stop coming, you also need to deal with the social determinants. How do you think about that, and what's your role in doing that to make sure that people don't come in as the first step of treatment, but there's other ways of addressing that?
Absolutely, and to that point, can you all hear me? Double mic now, double the voice, triple the voice, all of your community voice, and so there's twofold to that. One is this, and David talked about this morning about the paradigm shift. And we tend to think of paradigm shift in healthcare as technology driven, the disruption of technology. And I think the paradigm shift that's happening in healthcare is the idea that it's a patient voice. And so when we're talking about voice and advocating and speaking up, recognizing the fact that they're the part of the design thinking piece that corporations have figured out that you start with your user and you build that prototype around that user. It's the same thing with patient-centered care. And to that end, we put this into our Parkland strategic plan, and I actually oversee the program that's called the Patient Family Advisory Council. They're extremely engaged. They are representative of very, very diverse group of patients that have anything from chronic disease to clinic appointments to, they've just seen so much of our hospital. And within the first meeting, and I love sharing this because they come up with ideas that we would have never seen unless we had the patient lens. And so they are actually, so the outcomes that they're seeing, not just the number of patients that are on our advisory council, which would have been something that we would have collected that data on from an output standpoint, but the outcomes is the actual operational changes and process improvements that they're putting into place, just from the idea of, whether it's the access to certain prescriptions and the way that we document certain things, or and even from like a actual physical standpoint of, where the bus might drop them off to the hospital, to the walking distance to the actual entrance of the clinic. And so things like that, where they're actually talking about this from their perspective, so they're actually improving the patient experience. And so that's one piece of it, and how they're part of our care team. And the other piece of the social determinants of health, everything is prevention. Everything is prevention. So really the job in healthcare is really kind of working ourselves out of a job. We want everybody ideally to be healthy. And so where can we learn from and implement some of those changes here in Dallas? And what we're seeing, especially being coming from a very social impact perspective, is really learning from our global partners. I mean, some of the things that our partners up north, and I don't want to say Canada, yes, Canada with their national healthcare system, and the UK with their national healthcare system, where they've put so much emphasis on public health and prevention for so many years because it makes sense, because they're paying for their healthcare through the government, have actually come up with certain models of public health intervention and that we could adopt, and we could be saving the system, but it's also best practice. The idea of where economics and social good interact is in making sure that everyone has health care, right?
So I think John's mic is working, so
Good.
he doesn't need to double it.
They'll turn me down before it's over.
I'd love to hear, John, from you a little bit of two things you talked about in your opening. One, just how you got the community involved in running parts of the organization and input in, which is not dissimilar to what Parkland's listening to their community and thinking about. But also, how do you think about partnerships and helping? I know you partner with Parkland too. How does that work? How do you do it? What does it mean? And I have a very specific question, which is like, how do you pay for that?
Well, paying for that's always a challenge.
Yeah.
There's been an evolution for us where we kind of were so community-based that a lot of our best ideas came out of the community, and then we discovered partners as those ideas evolved. So our clinic in particular, it started really when a doctor out of his faith said, I'll come down and donate my time on Thursday nights. And so it was a clinic that was a charity clinic. And then we worked where we could afford a physician. So we hired a physician, and then Baylor came in and said, we're going to hire that physician away into our system, but then we're going to place that physician back. So now our clinic's actually a partnership with Baylor Scott and White, where it's a level 3 patient-centered medical home. It's as good as any of the other 80-something clinics in Baylor's system in North Texas. We score in the top 3 of all Baylor clinics in adult preventive services. So it's not the charity mindset, it's actually a functional, high-quality healthcare facility. That shift has taken place over years. And so we've had that partnership with them. That's now evolved into an expansion of that into partnership with Parkland as well, so that Parkland can take patients that are in the zip codes our clinic serves and make our clinic their medical home. So get them out of the emergency department into our clinic as a medical home. The partnership's also evolved into, we run a community health transportation program. And so we actually have drivers and vans that go out and get patients and drive them to their appointments in any of 9 community clinics within the Baylor community system. So those kind of partnerships have evolved over years. We learn what we can bring to the table. We try to advocate for our neighbors. In a lot of ways, we're just a village of startups and pilot projects because we really can't afford anything. But we have a bias towards action, so we tell our staff anything worth doing is worth doing poorly, which is probably the worst thing you can say on a panel about outcomes. But we think folks that sit around whiteboarding trying to figure out the best way to do things aren't doing anybody any good ultimately. Like, poverty is so urgent that whiteboarding is a luxury for the rich. But poor people are still going to be poor whether we do it well or not, so let's do it. Let's try housing even if we don't know what we're doing. Let's try access to healthy food. Let's figure out how to do access to healthcare. And what we've learned is if you do it, you become good at it. So we don't fear failure. And so we tell our staff, if you ain't failing, you ain't trying. And if this works well, it's because you're great. If it's a failure, it's because I suck. And so I've just kind of said, I'll own the failure. Now you're free to dream and to do and to be, and so push. We don't have stasis anywhere. We don't maintain anything. We drive every program to be better, to do more, and to disrupt itself. So there's no sacred cows where we say, oh, our sweet little food pantry's got to stay the way it was 20 years ago. It's always being disrupted with new ideas. And so you have to continually infuse that into the system. You have to tell your people, reward your people for creativity, for collaboration, for disruption. And so our staff has come to expect that, but it's been liberating that they know they're free to fail, and that if something's not excellent now, at least we're doing it, and we'll figure out excellent later. Now, what happens is we're then able to chase kind of pilot programs. We're not able to do things at scale, but we at least are able to throw something out there that then hopefully funders will say, yeah, I want some of that. Then we can, we prove up outcomes and then we can take it more to scale. But a lot of times we have to teach funders what done right looks like by taking risk, even though we don't have the funding yet. And so we're always peeling off as much as we can tolerate the risk within our budget. How do we create something that funders may go, yeah, that's a better way to do this? So we can't make that happen without really talented partners. And so I think that humility, that we know we're not going to have to do all things. So you find what others are good at and you come together. I think that's a real struggle for the nonprofit community is you're always dealing with the pressure of scarcity of resources. If you function out of a scarcity mindset and become competitive with the very people you need to be partnering with, nobody gets helped. And so sometimes it drives our development team crazy because Larry and I will raise money for other nonprofits. We'll say their idea is a great idea, but if we're not all in this together, and if we're not trying to solve the problems regardless of who gets the credit or even who gets the funding, then what are we doing?
Can I bring you to Georgetown?
Sure. I say I don't want you to pay for it. But so that there's kind of that spirit about us, and so no matter how big we get, we try to keep that startup mindset, and so we're always trying something new somewhere, and I think that keeps us honest and fresh. But it also means that we're a risk culture.
Yeah.
Don't come work for us if you want security and stability. The budget's always a challenge. The fundraising goal is always a challenge. Our budget's increased roughly $8 million in the time I've been here. It's increased about $3 million this year. And that's basically the reward of doing good work, is you get more good work to do.
Yeah.
Oh, you're getting people housed, how about you house more of them?
Yeah.
So that's kind of the essence of our work.
That's great. So I'm going to ask a question specifically. So this is my last question. So those of you that want to ask questions, there's a chair right here that says Ian Galloway, San Francisco Fed. Please come sit here because I'm going to switch with you in just a minute. But please do come and ask these questions. But I want to, both of you are about to start a partnership. You're starting a partnership. Let's dig into a little bit of the tactics for a second. How does the partnership work? Like, how hard is it? How easy is it? Is it a translational question? Is there funding available? How do you get there?
share a patient story actually. Just like most of you here, you've been working with Parkland somewhere or the other, right? And we have been working together for a long time because in this patient issue, frontline staff, they have relationships. And our CEO and their CEO have been, our founder have been working together, and it's for a very long time. But we wanted to take it to the next level. One story that I wanted to share was we had a patient who had about 70, 80 visits in the last year. And our social worker worked with CitySquare team and found a cottage because the patient was had mental issues and medical issues. And right now, no more ED visits, 0 ED visits. Patient is completely stable and able to keep their medical appointments. So
They don't come to the hospital.
they do for preventive care, not for emergency care. So the patient is stable. So how do we replicate that? You know, and it's not based on need and just because you know somebody, just by design. We want to make this a model of care where there is a partnership. We have a memorandum of MOU between the two organizations, so we share medical information. There's so much to do. We just wanted to get started. So let's talking more doing, test something, see what works and what fails, so that we can redesign and move on. With that said, we wanted to focus on high utilizer, high risk patients. So we went through the zip code who qualified for CitySquare services and try to see, and so we came up with a list of patients. So now we're going to go through together on who we can, the low-hanging fruits of people we can make a difference on. And once we stabilize them, we'll still keep an eye on them, work on the next 5 patients. And that is where we wanted to get started and keep going. It's more about the sustainability. We don't want, even though we crave to fix everything right now, it's more about building the design so people who will come after us can still continue to grow it and sustain.
And how, both Vidya and John, both of you talked about this iterative culture of learning and then implementing. How do you scale that? I'm serious because it feels like there's a lot of little things we can do and may not add up to scale. But how do you think about that for yourselves?
That's a great question, right? So scalability is very interesting, especially when you have like the startup culture mentality of diversifying our portfolios to doing as many things as we can to see which one has the highest impact. And I think scalability comes in when you actually can show that outcome measure of success, and then you can get funders involved. And I think what we've started seeing is the momentum that we set forth for certain projects. We actually were able to do collective impact grants. And so bringing in other people, so one of the initiatives that we're working on is recognizing a gap in care for respiratory health. And bringing in a lot of our healthcare providers in that space and recognizing that, wow, none of us, we all have services, we all have the need, but none of us is really focusing on that. So can we do a collective impact grant? And so we've got a great idea. We're trying, we're testing the waters, and we're bringing in all the other healthcare providers, all the big players, all the community stakeholders together and doing a collective grant, and so to see if we can scale this to the other hospitals, right? So that's helped us a little bit pilot things at Parkland and then be able to share best practices with other providers, see the add value, and then have them kind of, again, collective leveraging, have them take kind of a piece of the pie and implement it without having the risk or burden because we've already piloted it.
For us, we tend to pioneer. We haven't scaled as much as we've pioneered and created new ways of looking at things or new possibilities. Sometimes then those things get taken to scale. We very rarely have the funding to do that ourselves. But our clinic became kind of one of the first where then Baylor said we ought to do more of these. So now there's 9 community clinics throughout the Baylor Scott & White system. Our clinic was a place where the neighbors in the community were taught how to manage their own diabetes. And so a Latino woman from the community got so good at managing her own diabetes, she became a diabetes educator in the community and was teaching all the other women in her community how to manage their diabetes. And she ended up going to Cornell University to present a medical paper because it was like visionary, oh, hey, people in the community can manage their own diabetes. Well, then Baylor professionalized that, where that's not something that's coming out of CitySquare now, but now they have that position throughout their system because they saw how well it works in the community. So we now have diabetes educators in our clinic that are actually Baylor staff. So it's lost a little bit of the grassroots feel, but it was within the community. We had the Latino community from our clinic put together a telenovela. This soap opera that it was all about how to manage your diabetes. They created a cookbook. And so we've done things like that then get taken to scale through a healthcare system. Housing, we did 50 cottages for 50 high utilizers. So one of the high utilizers that we met was is the one he speaks of in the Parkland ER. That 70 to 80 visits or whatever they had. I think it was still something like 40 visits a month just in their system, and probably was the same at Baylor and maybe even at Methodist. And that person's been in their ER 3 times since November when they moved into one of our cottages. That's a project that we think there's a business case for, that folks are staying out of jail, they're staying out of Parkland's ER, they're staying out of mental health hospitals. So on average, we say they cost the county $40,000 a year a person to be on the streets, and we're housing them for $15,000 a year. Well, that project's been going on a little over a year. We don't know how we're going to take that to scale, but one of the things I'm trying to get hospital systems to consider is, would they do housing with us to deal with that social determinant, and could it be in their best interest? It's hard for us to fund housing deals with our budget that we could take to scale. So we pick off a deal here or a deal there, but if we're really going to deal with the issue of affordable housing and what kind of social determinant it is for a costly high utilizer population, I'd love if hospital systems started doing that with us.
It's a great idea of thinking, a great comment that you're making even about yourselves, which is you may not be the scalers, but you'll work with others who do scale. So that's a great point. I've got a question here, so I'm going to switch out.
Hello. Never had an asked a question like this before. My name is Parker. I'm from the nonprofit sector, and then I also do some community organizing. So my question is more for you two. I'm going to ask you a big question that I know is not one hospital's job to fix, but among people that I see, and among the organizations and communities that I'm involved in, whenever I think about investing in what matters and kind of why we are all here to begin with, one of the things that keeps people down the most is debilitating medical debt. And to what degree are you guys as a hospital trying to address that?
I agree with you, that is a problem. The cost, first of all, there are so many low-hanging fruits, and trying to reduce the waste or unnecessary tests. There is, due to a lot of lawsuits, physicians have got into the habit of doing defensive medicine. Right? So, how do we make people, the clinical teams, comfortable so that they can do what is the needed rather than trying to protect themselves? So that is somewhere to start. But also trying to work on primary and secondary prevention. One of our goals for the Community Health Institute is try to keep patients healthy in the community, both not just healthy but also productive and have a good lifestyle.
And I'm sure preventative care is definitely needed, and it's a great value. But for some people, it's just in their genes, and it can still be something that they could do the right thing their entire lives, but because of unforeseen circumstances, they could still end up with monumental amounts of debt. Specifically, I don't know how much you could speak to y'all's relationship with insurance companies? Because I know that in this whole issue of medical debt, they're a major player and might be argued a major problem.
So Parkland is in a different position, and so we're trying to talk about medical debt and the accrued costs. And because we're the safety net provider for Dallas, so all of you who are in Dallas County, raise your hand. You kind of own Parkland because a portion of your taxes are going to support the care at Parkland. And with that being said, we did over $700 million of uncompensated care last year. So what is this uncompensated care pool? It's for the individuals that you're talking about who cannot afford care. So not that we're going around, it shouldn't be advertised that we provide care for those who can't afford it. It should be something that we should all be doing because it's the right thing to do is to afford, not being able to affording care isn't just for those who have chronic conditions. And I give this as an example because we tend to, from the health equity lens, think, oh, those are the impoverished people who are taking in or tapping into that need and using what we call the Parkland PFS, with Parkland Financial Services sliding scale insurance plan that we offer ourselves. Actually, one of my friends, who is a struggling artist, chose not to have health care, but this was before the ACA, so she wasn't able to afford care, and was doing a mural on a ceiling and fell off the ladder and had a spinal cord injury and was taken to Parkland and received incredible care, but she couldn't afford that care. And so it is looking for those opportunities and grant funding and federal dollars and tax-supported dollars and charitable care that we're really tapping into to be able to give care to everyone. So medical debt and specifically medical debt for our patient population, it's I don't know if it's as relevant as private health care, but I do want to say that is an issue, and I totally understand that you're worried about it.
Okay, and I just have one more question. So if, being that you guys are, subject to elections and the community and all this kind of stuff, what would you say, if there was a coalition of people in this room who were had hundreds of thousands of dollars worth of medical debt, what would be your advice to them and with ways that they could take their power as voters to change policy to help alleviate that problem?
So this is Vidya wearing her Vidya community activist hat and not just speaking on behalf of Parkland. So I will say that as with any issue, if you're asking for the sake of medical debt is one thing, but for any issue, you have way more power at the local level to talk to your local elected officials, to make sure that policies are reflective of anything that you might need as a community. And if you're experiencing things where your policymakers are the power of the collective voice, the power of your individual voice and the power of the collective voice, and how I, on my spare time, encourage people to go and speak to their elected officials about issues that maybe that you like you specifically care about medical debt. There's a lot of other issues that groups care about, and I think that it is very important to take an active role in local elections, and that's the only piece of advice that I can give, and kind of encourage everyone to take part in, and it's not necessarily specific to medical debt. And I don't know what else to say. From a federal level, we could get ourselves into a long conversation here of ways in which we can influence policy or encourage policy. I think that action is speaks louder than words sometimes too. So to take collective action is very important.
Thanks.
Other questions? I can keep asking questions, but, I may not be the most interesting person here all the time. Other questions of thinking about models for health and improving health? Come on up. Grab a mic. Oh, go on. Come on.
That's fine.
It's good for them to talk to you directly.
All right, so I grew up in the Rio Grande Valley, along the Texas-Mexico border. And one of the health innovations down there in an extremely medically underserved area is promotoras. The promotora model is basically healthcare workers. And it's really looking at it from a different dynamic. It's not about the doctors and the nurses. It's about preventative care from the inception. Is that a model that Parkland, our community, is embracing? I think our community in the Rio Grande Valley was just sick and tired of being sick and tired, and they took it upon themselves to educate mostly women to go out into the community and be those health advocates on behalf of that client. And the outcomes have been amazing. And I'm surprised that I haven't heard more about it across the country.
One thing I wanted to share is the thing that me and Vidya were talking is the future of healthcare is community health workers, not technology. So that is what we need to invest. It's about, I'll give you a couple of stories. We decided to select our high-risk, high-utilizer patients in each of our clinics, so about 50 patients, and work on them for a year. It's a multidisciplinary team addressing both their clinical and their social needs. And our goal was 20% reduction in the ED visits. And to our surprise, there was a reduction of 70%. So now we are expanding fast because it goes back to showing outcomes. It's not only reducing the ED visits, but we also want to make sure that they're keeping their primary care doctor appointments so that they're getting the regular care. It's not that they get lost to care or go to another facility. The other example I wanted to share was we did a walk around CitySquare talking to patients of people who are living on the streets, trying to understand how we can be of help. The first two people we met sleeping in the street were Parkland patients. And one of the lady she said, oh, I go to the oncology clinic at Parkland. Like somebody with cancer sleeping in the streets. But I'm not sure if the people who developed their care plan thought about how are they going to execute whatever we asked them to do. Just print the sheet and give it to them. Then, in our previous discussion, when we talked about education, they're worried about paying the bills and the rent and all that. So it's the same thing. People don't worry about taking their medication when others are requesting. So absolutely, I agree with you. We need people.
I'll jump in too. We have a program going on right now, a pilot program, where we're training barbers and beauticians in South Dallas to do preventative healthcare work. So they'll check the blood pressure of somebody whose hair they're cutting, and then say, whoa, this is really high. So we said, who are the leaders in the community in South Dallas? Where do people go? Well, one of the community hubs is the barbershop or the beauty salon. And so we're training barbers and beauticians to be the front line in a couple of different preventative healthcare metrics. Where then if they find somebody that's hypertensive, they can direct them into our clinic. So before that, there used to be Project Access, which was a partnership between the medical society and the hospitals, where it allowed uninsured working folks to get access to specialty care. And we ran that with community health workers. So we were training folks from the community who then helped people access specialty care that the hospitals and medical society were coordinating. When we didn't expand Medicaid in Texas and they came up with this 1115 medical waiver, there was a fight over that. It's called DSRIP, that DSRIP money, and the Project Access went away. But we used to train community health workers for Project Access as well. But so that's been effective in our work. The barber shop's our latest kind of cool little, let's try something new and different. We're doing that in South Dallas right now. We think it's going to lead to some great outcomes in that community.
Okay. And to that point, this is the exact model that we're looking at too. I feel like Roy asked this question to make us look good because we have all of this innovation happening in the community health worker space. And another point that we're leveraging is actually a faith health collaborative. So recognizing that there's so many congregations in the area, and within that network, having members of the congregation come forth as wanting to be kind of healthcare leaders in their faith health community. We're training them, giving them extra curriculum to be able to look after. And so it's kind of this upon discharge piece from the healthcare standpoint. The hospital providers also have a pastoral care when you're in the actual hospital, but when you're being discharged, it's the community that cares for you. And so if you're already belonging to a congregation and having a support system within that network, we're working on that, and that's kind of based off of Memphis's model. But we're also incorporating a CHW, injecting the community health worker, which is a state level program, the Promotora program, into the hospital for addressing social determinants of health specifically.
Yeah, and the really good ones will address issues related to housing, workforce, other transportation. So you name. Thanks, guys. Appreciate it.
Texas is the only state that actually certifies CHW.
I don't know if they're the only one, but they do. Yes, we have somebody on our staff that can do the certification process.
There are other states doing this actually on a national level. They're looking at it from a national standpoint of how we're doing it in Texas and adopting that model. But there are CHW kind of models that it actually stemmed from Chicago, where their model of healthcare was very community based. And just like the story that John said earlier of the woman who took it upon herself to become a diabetes educator for her community, it's the abuelas of the community, the ones that really everybody goes to for help anyway, and identifying them and giving them the resources that they need for social education.
So one final question, rapid fire answers from each of you. If you wanted to get started in thinking about how to approach an outcomes-based way of doing healthcare, where would you get started? So what advice would you give to people?
Patience. As with everything that you're trying to do with outcomes, we can't be prescriptive anymore in any industry. It always has to be your end user. So think of your customer base. And for healthcare, it's our patients. So involving them in our care, involving them in the processes that we are about to implement, any new model of care that we're thinking of, care delivery models, everything involves the patient as that initial person that we go to.
I think if you're in the nonprofit space, collaborating with the healthcare system, because the system is geared toward metrics and outcomes anyway, but then a conversation where you help broaden what metrics are considered. So, they may be looking at clinical metrics about what did their blood do, but you can expand and say, okay, here's some social determinants of health or quality of life issues. Hospital systems usually have the mechanism for getting outcomes and evaluating them. Then we can bring some of the human design to that, and it's a really good partnership.
Healthcare is all about clinical outcomes, right? Diabetes and the other diseases. That's how we come up with best practices. But healthcare is beyond, I'm realizing it is beyond just treating that disease. It is about the whole making sure that they have a productive life. And what is the measure of that? I'm still trying to figure that out.
I think what you hear from this panel and what you've heard from this morning is whether it's education or whether it's healthcare, there's no one single point. There's only one way to answer it. It's thinking about the community around it and thinking about how the community is addressing the problem, not just physically a community, but the community of issues around how to make sure someone can graduate or how to make sure someone doesn't have to come back to a clinic or a hospital, but really thinking about the 360 around everything that we do And most importantly also, and I think one of the things that we kind of touched on here, but also thinking about how we incentivize that payment. So we're not just paying for a number of people that can walk through a door, but really thinking about how we also pay for achieving the outcomes, which requires, I think, what John and Vidya and Dr. Kumar have also talked about, a little bit of testing and being willing to test ideas, throw them out if they don't work, and retest them again if they do, and try it again many more times. There's a little bit of a fear sometimes of trying new things, especially amongst funders, but also thinking about how we can do that effectively. If the comparison we're making is the current status quo, that's not good enough. So if the fear that we have is it might not work, it's already not working. So I don't know what we're fearing against. If the question is, let's try something because it might not work, maybe the beauticians and the barbershops don't work, but at least it's worth a try because the status quo is not great. And we have to be willing to push beyond the status quo.
Real fast, I'll give you a great story about when it doesn't work. We used to have a youth, we hired youth from the community to be youth counselors, and they got paid to run immersion camps where like youth groups from the suburbs would come in and do an urban immersion. And so urban kids were getting to be these youth volunteers and youth leaders. We also started as a social enterprise, this lawn business, and it took off and was making all kinds of money. And so it kind of got off mission when we were having to just get bodies in there. Well, our crowning moment was on a Friday when our banker called Larry and said, "We've got a problem, you need to come down here. Your yard crew is selling weed to your youth volunteers." So that's one of our favorite failures, is when we had to end our lawn business because we were dealing in the wrong kind of weed. So.
All right, I can't top that. Thank our panel for
So surely you won't be done.